Thank you very much. In my part of the world where we live, we still see quite a lot of PVR. So I'll be doing 3 presentations. I'll be illustrating different issues relating to PVR, retinal detachments, and subretinal bands. So the first case is a chronic retinal detachment with moderate vitreous hemorrhage, cataract, and undilated pupil. He had synechia, and indeed, most of these patients, when they come, they've lost the other eye, and they've taken so long to come back to see us. So in this case, the pupil is tucked down. An ultrasound shows us there's a retinal detachment, so we're able to do a phaco. And he has a vitreous hemorrhage, as we can see. And basically, what we do is, okay, the video is still on, video one. Yeah. So what we're trying to do is to do a retinectomy. We use 23 gauge inferior retinectomy. Already we knew there were subretinal bands. So doing an inferior retinectomy with a cutter. And here we can use the cutter to extract the bands. So that's the subretinal space, and that's the band being removed. They usually present with very extensive bands, and invariably, in some cases, the amount of PVR you see on the surface of the retina is not as much as you see under the retina. So this is a band being removed with a cutter, and we still look for more bands. Going subretinal. And with the cutter, we're able to extract the bands. Usually, I rarely do bimanual surgery for these cases. I'm able to do the surgeries with unimanually. So after extracting the bands, we do air fluid exchange, typical laser, and then silicone oil usually in these cases. As I said, most of these cases, this is their only eye, and we're just trying to salvage the patient to get some form of navigation vision. And this is a second case. So this is silicone oil, that's the second video. A second case, chronic retinal detachment as well, with severe vitreous hemorrhage and very extensive subretinal hemorrhage, as you can see from the video. So he had a vitrectomy, broad retinectomy as well, and then removal of, he had not just band, but membranes on the subretinal space, the video. So that's, we start to do the cleanup anteriorly, 23 gauge as well. He's pseudophakic. He's actually a very young boy, and that's what the retina looks like. He has kind of napkin light traction. And so we do another inferior retinectomy.
May I interrupt? While you're doing the retinectomy, I can see it now, you have a PFO bubble, the heavy liquid bubble to help stabilize the retina? Is that what you're using there?
In this case, we didn't put a PFO because I didn't feel there was need for me to have a PFO since I was still going to be going behind. So we're removing the subretinal hemorrhage there. And here we instead of we use a forceps, a 23 gauge forceps to do the pill because it wasn't just the band, but a lot of membranes. So one thought that comes to my mind is if we should stain in order to see all the membranes because there's so many of them. Mm-hmm. And so I decided to use the forceps and he had a lot of subretinal hemorrhage. And so we do a lot of peel, remove all the bands, as much of them as we can.
Do you worry about if you were thinking of staining any toxicity because you're under the retina?
Yes, that's why. It's I think it's an issue to discuss in this case, mm-hmm. And I'll bring up that point. But here we're just peeling the retina, and after peeling the retina, you can actually reposition the retina. So invariably, many of these cases do get 660, 636 vision. They're able to navigate, and it makes a whole world of difference to their life. So air fluid exchange, and then silicone oil again. So this last case was that of the next case, please. The third case is a patient who had trauma. It was an only eye. He was 13 years old, and he really wanted to go back to school. His vision was, I think, perception of light when he came to see us. And he had a dislocated lens slide. Video, please. So that's the ultrasound scan, and that's the lens that was dislocated at the time. So the 23-gauge surgery as well. So we had to extract the lens with the capsule already wrinkled. This was a very tough surgery. His vitreous was completely attached with a total retinal detachment, and it was a very difficult case. We tried to do the peel, but it was really difficult to be able to peel the vitreous. In fact, it was literally impossible. We had to put in PFO. We tried several times, had to put in PFO. And then stain again.
How old was the patient again?
Oh, he was 13 years old. He was very young.
Yeah.
And this was his only eye as well. And so put in PFO, put in triamcinolone, and then we were able to, we managed to get to induce the PVD. But that just wasn't the only issue in this case.
Yeah, being post-traumatic and young, I can imagine the hyaloid being a
Yes,
huge
Young.
issue with this.
Yeah.
Young patients.
Half the battle, I'm sure.
It's very difficult.
So I would like
Professor-
to know from the panel, maybe later on, what their preferred technique would be in this kind of case, because this took a long time to be able to peel the vitreous and to get it out. And being an only, I wanted to be sure that the vitreous was completely out, and that would give him the best chance. So after a very long while of making several attempts, I don't know if there's any trick to doing this easily, but after a very long while of several attempts, we were able to get the vitreous out. And but that wasn't just the issue here. After getting out so now the vitreous is coming up.
Can I comment on something?
Yeah, please.
Actually, it's really very difficult in such eyes. I totally agree with you. But what I would do this one, I mean, I would increase the PFCL bubble size, and I would do bimanual technique, because you just took a part of the posterior hyaloid with one hand, and with the other hand you release the other part while you are keeping the first part stable. That helps, and the PFCL is keeping the other part at the backwards. So you have 3 hands now, and it may help in such eyes, especially in pediatric cases, pediatric retinal detachments. You need to do this maneuver in almost all of them when you do vitrectomy.
Do you
so
do
by
two-
menu.
Do you do 2 forceps? Do you do a forcep and a pick? A
2
forceps?
forceps.
2
2
forceps.
forceps. I do it with 2 forceps.
Dr.
Thank you very
Teixeira,
much.
did you?
Yep. So the point, the next slide. Well, the point in this case is also, one of the points here that I decided, because he had so many bands very close to the macula, and I was scared, I was worried that the concerns of a macula, inducing a macular hole while trying to peel, I decided to retain all the membranes and not to go to do a retinectomy. And so you can see that he has there on the slides, these are the bands. This is about like, and then that's the OCT. The first month OCT, there was still some wrinkling of the retina, but you can see from the 5th month, he started having a somewhat better configuration. And those are the bands, the subretinal bands we can see. And one thing I noticed also was that the choroid seemed to get a bit better from as we progressively monitored him. We were able to take out silicone oil, and he's doing relatively well, but much better than I ever assumed he would.
I agree
So,
with your choice to not remove that subretinal band.
Right. Yes,
Considering
I
you
think
can see the phobia right there.
Exactly, because it was so close to the phobia, and I was very worried about what we had. But I had a discussion with the parents and said, look, if these bands, because they were very, if you looked at the video, they were very taut bands, and so I just incised them, I just cut them, and then lasered around them and let them be. So
Do you routinely use triessence or triamcinolone to stain the vitreous gel in your diabetic patients?
Oh, yes, we do. I do that, yes. And actually, my diabetics, the difference between my diabetics and this is that in these cases, I usually would do 23 gauge, But in my diabetic patients, I would prefer to do 25 gauge. And I will do bimanual techniques in my diabetics. But usually in the PVR cases, I will do, well, I'm learning something new about doing the double forceps. But usually I will do just a unimanual surgery and not bimanual surgery in this case.
Okay. And I just want to add one more thing. In young patients with chronic inferior retinal detachments, they usually have many subretinal bands. And subretinal PVR is much more than pre-retinal PVR in some cases. And in those cases, I usually prefer to do just scleral buckle without vitrectomy, and it works very well in those eyes. I try to avoid from vitrectomy, to avoid from retinotomy and the silicone oil, all those things. So I can say that in young patients with subretinal PVR without too much pre-retinal PVR, please try to avoid from vitrectomy and do just scleral buckle.
Dr. Yanakawa?
Usually, if a kid comes in with a chronic detachment, they're usually chronic, right, all the time. I agree. I think there's more subretinal material because the vitreous is formed. You never had that subretinal fluid come into the vitreous cavity, and so it's all subretinal. That's why you get those bands, and usually a buckle does the trick. But I think in your case, it was so extensive, like so extensive. Yeah.
It was a trauma, and the lens
It was
was
a trauma
dislocated.
case.
Yeah, it was a trauma
Yes,
case,
yes.
and the lens was dislocated, and he had so
You
much
had
pathology.
to
Yes.
get inside. But if you get inside the eye, you must clean everything.
Right.
And it's like that. It takes a long time to take the highlight. There is no forceps, no, just time. And then suddenly it comes out.
Right.
That's a great case.